Hi, Usna. Can you just tell me whether you can hear me?
Yes, doctor. I can hear. I can hear you.
Clear enough or not? Because the microphone for my computer is not that great.
Okay, doctor. Yeah.
Anna, can you see the slide?
Yes.
Yes. Your first, is it?
Yes.
Not really. How many in your group, Usna?
Doctor?
How many in your
9.
Hi, Fariha. Hi, Fariha.
Hello.
Hello. Everyone. We're waiting for your friends. You might as well. Got around. How many people already? 1, 2, 3, 4. While waiting for your friends, you might as well use your time. And watch a video.
Today, as he was obviously very active, very strong.
I have a question. If I talk while the video is playing, can you hear me or not? If I talk while the video is playing, will you be able to hear me? I try, then you tell me can hear me, okay?
Okay.
She wants to be. I think the main abnormalities I saw were when examining her gait. She found it quite difficult to walk on her heels, and also even with a normal gait, there was some sort of slight subtle foot drop, which seemed to be fairly symmetrical and bilateral.
We can
Cannot
hear
hear
you,
you.
but tapi macam tak jelas.
Not very clear, Doctor.
So basically, if I play the video, then korang dengar je lah. I will speak during the video lah. Okay? Because today will be a lot of video. Because since you guys tak pergi ward, so will be a lot of videos. Basically a lot of video watching lah. Okay? So in between presenting, you guys will be looking at videos basically of clinical signs and symptoms. Okay? So today, I think we'll not really cover respiratory, but kind of look at the signs and symptoms of basically respiratory disorders. Okay, so we're going to start off a little bit about berapa orang dia sekarang? 7. Lagi 3 kan? I'm going to start off a bit with how to recognize respiratory distress. And then after that, I'm going to watch a few videos. 2 of it will be about, I think 3, tengok masa. how to examine. And then the last one would be kind of like not really a clinical scenario, like it's a meeting in a pediatrician seeing a patient in a clinical setting. Okay, and then I'm gonna look at a few chest X-rays and stuff like that. So basically a lot of videos, also a lot of things on YouTube. 3, 4, 5, 6, 7, 2 lagi. In between, you might as well just watch how to do neurological examination. Since you're already here, nak tunggu satu lagi. 3, 5, 8. Korang lagi kan? Yes, sir. Do you want to say something, just unmute and then say your name and then just say whatever. Okay?
Okay.
Okay, Doktor.
Korang lagi? Siapa? Siapa yang tak ada lagi? 1, 2, 3, 4, 5, 6, 7, 8. We wait for 2 minutes. Anybody want to watch? Anything? You want to watch a neurological examination? Angguk ke? Giling ke? You want to watch a neurological examination pun tak? Dah nak tunggu. Semua orang dah ada dah. Yay!
Dah ada.
Okay, we're gonna do respiratory system lah today. Okay? No long case presentation because korang tak pergi ward kan? Tak pergi ward kan?
Tak pergi, Doktor.
Nak pergi ke? Nak pergi. Aku cakap dengan Dr. Taufik. Do respi. First, we're gonna talk about how to recognize respiratory distress. Just a short slideshow lah, but in between there's will be a lot of videos. Then we're gonna do videos on how to examine the respiratory system. So there'll be one guide video, another one where a master student is taking the exam. And then after that will be a pediatrician in the clinic seeing a kid with a respiratory problem. Okay? So, and then after that, there are 3 chest X-rays. If you hear kids screaming, just ignore. Okay, so we're going to start on about respiratory system. Like I said just now, respiratory distress, how to identify, then go on to respiratory examination, the technique, and then a video of acute bronchiolitis in a clinical setting. So in respiratory distress, we're going to have an introduction, then we're going to talk about all the signs of tachypnea, nasal flaring, retraction, recession, sorry about the typo, grunting, seesaw breathing, head bobbing, stress response and respiratory failure. Cyanosis also is included there. Now, respiratory distress is one of the most common presenting signs of illness in a pediatric patient. So it can present as a sign of a systemic problem, not necessarily related to the lungs, so such as in sepsis, you got heart failure, you got metabolic acidosis in severe dehydration, or like paracetamol poisoning, you get toxic ingestion. But by and large, most of it is caused by a primary pulmonary problem. Now, first thing is usually about tachypnea, right? So tachypnea. So when a child has a problem of any kind that interferes with gas exchange, you need to excrete more gas. So it's the most common and universal sign of respiratory distress in an infant or a child. Now, the values change depending on age. Usually how I remember it is by remembering the age. So I go 0, 2, meaning 2 months, 1, 5, and then more than 5. So you remember 0 to 2 months, you just go by 60, 50, 40, 30. So if the child is less than 2 months, it will be more than 60 is tachypneic. If the child is less than 1 year, be more than 50. If the child is less than 5 years, be more than 40. If the child is more than 5 years, then be 30. Okay? If I'm going too fast, you guys just stop me. So we're going to watch a video on a kid in respiratory distress. You can see that child's tachypneic, then also got the other signs also, okay? So what did you guys see in the video just now? Anybody can say?
Oh, yes.
Anybody who's now?
There is increase in respiratory rate.
The child's tachypneic, right?
Yes.
Afiq, nampak apa Afiq? Afiq Syami, nampak apa?
Nampak tachypneic, and then nampak increase in respiratory muscle work.
Okay, so you got increased work of breathing. So you see the recessions, right? Nampak intercostal recession, subcostal recession. I know there's a Rouse tube, tapi if you see behind the Rouse tube, nampak nasopharynx tadi kan? Okay. Okay. So next one will be nasal flaring. So it's basically a way of increasing the size of the upper airway. Okay, so this is how it looks like.
So what we're trying to look at here is nasal flaring. See if she's going to cooperate with me. There we go. Take a deep breath. Okay, here.
Okay.
She was a premature baby, right?
Mm-hmm.
Yeah, so that's nasal flaring. So this may end up on YouTube just as an example for teaching other doctors and nurses what nasal flaring can look like. She was she here yesterday for wheezing too?
She got an appointment with her Paediatric.
We also maybe a little bit of some suprasternal retractions. Her lungs don't sound too bad. I listened to her, but that's after a breathing treatment. So.
Okay, so that was nasal flaring and a bit of sternal retraction, or sometimes you guys like to call it a tracheal cup. Lagu sedih, I don't know. Okay, next one. Next one will be retractions and recessions. So it occurs when there's a collapse of the soft tissue because of muscular effort. So retractions can be seen in a few places, right? So, Irshad, where can you see recessions or retractions? Bukari, where can you see recessions or
intercostal recession.
yeah, so in between the ribs, intercostal recession. Azri, mana lagi? Azri.
Ni subcostal recession and also
Yeah.
intercostal recession, subcostal recession.
Okay, so subcostal recession is when your abdominal muscles retract quite forcefully, right? So you can see the edges of the rib. Fariha, lagi, mana? Dah intercostal, subcostal already, where else? Tadi dalam video tu?
Suprasternal.
Suprasternal. Alright, so there's suprasternal, there's intercostal, there's subcostal, kan? And then sometimes in a very young infant, kan, so the sternum is quite collapsible. So sometimes you can see a sternal retraction, that means the sternum itself looks like it's going in. Okay, so let's watch more videos. Okay, so tadi you can see quite a number, kan? So you can see sternal retractions, head bobbing. Later on, I'll explain a bit. Then you got the tracheotomy, the suprasternal retraction there. Lots of intercostal recessions. Also, you can see the paradoxical breathing, that seesaw breathing, when the child is very, very ill, going into respiratory failure. So this one would be another recession, I think. 1 minute and 20 seconds. Yeah.
So this is what we call suprasternal retractions. You see the soft tissue becomes more prominent every time he breathes because it's pulling. These are what I call intercostal retractions. Every time he breathes, we can see the ribs, and those are obvious signs of distress. And of course, the speed of the breathing, which is what.
Yeah, I even tried telling him to put his hands over his head and take
Probably 40 something a minute, you think, Justin?
It's like 46.
46.
I'm 42.
Now, let's take a listen to what this patient sounded like when listening.
Okay. So that is a sternal retraction. If it's a younger baby, right, because the neck is quite short then. So usually what you do is you need to make them look up a bit and then you can see whether there's a tracheal cut. With a younger baby lah. With a kid, then the neck already long, then you can see like when they're breathing in there. But if it's a baby, sometimes like that, you distract them, make them look up, then you can see the suprasternal retraction. But anyway, if you can see the intercostal recession, subcostal recession, usually the child is already quite distressed.
Doctor, I'm sorry. I have a question. In the video just now, the doctor mentioned that there's presence of pulling of soft tissue. Why is it?
That's the suprasternal retraction. That's the suprasternal retraction, meaning his book of breathing is very great. So he's breathing in hard, meaning this soft tissue lah. Basically the area around your neck, so that's why you can see the notch going in.
Oh, okay. Thank you, doctor.
Grunting. Heard grunting before or not, you guys? So what's grunting? Any idea, anybody? Siapa tak jawab lagi? Balkis! Grunting tu apa?
Macam mendengus.
Macam mendengus. Why you get grunting? What are you trying to do?
To keep the airway open.
Yeah, try to keep their alveolus open. So that's what we call to give themselves some peak positive and expiratory pressure so that they keep the alveolus open. So what they do is they close the glottis and then you breathe against a partially closed glottis. So you get a sound like so that's grunting. Okay. So there. The baby or the kid tries to maintain lung volume by closing the glottis and breathing against the closed glottis with positive and expiratory pressure. So it's low pitch deep in the throat because that's where the sound comes from, because the glottis is in the throat, right? So this is how it sounds, and then later you can see the video.
Characteristic that the moment I made you listen it, you will remember it for lifetime. So let's listen. Grunting occurs when expiratory efforts are made through a partially closed glottis to increase and expiratory pressure to prevent collapse of alveoli during expiration. The grunting sound, listen it again. This sound occurs during expiration against partially closed glottis. There is usually no inspiratory sound produced during grunting. Grunting is a sign of respiratory distress and should always be given due concern. That's all for now. We'll see.
So that's how grunting sounds. There's another video here for grunting.
A respiratory distress syndrome is grunting. Listen it again. Grunting is baby's attempt to maintain alveolar volume by prolonging and increasing expiratory pressures by breathing against a partially closed glottis. Based on present
Okay, so that is grunting. So it's usually you hear it during expiratory, so by the time the kid starts grunting already, they are already quite severely in respiratory distress already. So if you hear that, you better be vigilant. Okay. Next would be hero breathing. We saw a few just now already, right? It's basically when sometimes they call it paradoxical breathing. So where the chest and abdomen, they move in opposite way than they usually do. Usually a sign of lower respiratory obstruction, they need to force the air out of the respiratory tract in diseases like bronchiolitis or asthma. So here.
Do you know what's going on with this patient?
This was the same.
Probably 40 something a minute, you think, Justin?
It's like 46.
46.
42, 46.
Now,
Okay, so basically, like when the tummy goes up, the chest goes down. When the chest goes up, the tummy goes down. In younger babies, sometimes they get abdominal breathing, so it might look quite normal in a younger baby. You might think the abdominal breathing is a seesaw breathing, but actually it's quite normal. But if the child is older and you see that type of breathing, that's definitely not normal already. Okay. How you differentiate, you need to look at more younger babies. So go to the ward more after they open the ward for you guys. Okay? So head bobbing, we saw one video before that, right? So it's usually a fairly late sign. It tends to occur in a baby who's becoming lethargic, but there's significant increased work of breathing. So they're already tired and still breathing very hard, so the head going up and down. So by the time they already reach head bobbing already, you need to be quite careful. They might go into respiratory failure. Okay, so that's head bobbing, right? That's what we saw previously also. So if you see that in a baby, then you need to be careful because they might go into respiratory failure already. So you have to be aware. Maybe the child will need assisted ventilation. Last one is first response and respiratory failure. So babies and kids who have significant respiratory distress, they'll get some sort of first response. So usually what you see will be tachycardia, heart rate will go up, right? Sometimes you can get a transient time when there's slightly hypertensive because of the stress, but then later on they become hypotensive when respiratory failure sets in. Sometimes you read what they call air hunger, where they look very uncomfortable. They have this anxious and worried face. Okay, then this is also when cyanosis comes out, even though cyanosis may come at any time. Okay, what is this? I forgot. This was the first one just now, sorry. This was the first video just now. Need to see again. Nak tengok ke tak nak? Nak ke tak nak?
Tak payah.
Nak ke tak payah? Just watch us 1 minute and okay. There we go. We'll go on to respiratory examination. Okay, so those are basically the signs of respiratory distress that you guys know, tahu and recognize lah. Okay, so you see those sort of things when you do your short cases or your long cases. It's important for you, if you're doing a respi case, important for you to state whether the child is in respiratory distress or not. Okay, so if you don't need all of it to be in respiratory distress, things like tachypnea, then most likely it's respiratory distress, but things like nasal flaring may not be. So it's like something like If the child only has nasal flaring, not tachypnea, no recession, things on air, maybe the nasal flaring is because of something else. But respiratory rate, if the child's tachypnea, if the child has recessions, then definitely you say, when you present, you say this is a 2-month-old child in respiratory distress, as evidenced by tachypnea of a respiratory rate of 60 breaths per minute, presence of intercostal and subcostal recessions, and suprasternal retractions, right? But you don't need all to say that the child is in respiratory distress. Now, which one was it first? No. Okay. Anything you want to ask, Mark? Kalau tak ada, we just watch how to examine. Ingat lagi tak macam mana?
Doctor?
Yep.
I just wonder why in respiratory stress the child can sleep like in the video. He has head bobbing but still can sleep. I thought that in respiratory stress the child will be quite irritable.
That's already. Asma kata, that's not sleeping already. That's the child being tired already, lethargic already.
Okay.
Usually what happens is when they're not in distress, they're quite alert, right? And the more and more distressed they are, usually before they become offended, they are anxious first. So you buat apa pada you dekat pun, you sentuh dia pun, dia don't want anybody except for the mother, right? After that, they tire out, then that's why head bobbing is a late sign. So by the time you reach head bobbing, most likely they are already very, very, very tired already. Right? So that kid wasn't sleeping. That kid was actually already tired out, lethargic. That's also the other reason why I don't like you guys to present when you present short cases. I don't like it when you guys say that the child appears lethargic, because lethargic can also mean assessment of the mental status, meaning the child is already tired out, not fully, GCS is not so full yet. Full already. So that child was actually not sleeping. The child was already too tired already because of the respiratory distress. Okay?
Okay, thank you, Doctor.
Good morning, Sophie and Ellie. Thank you very much for coming in this morning. I'm Elaine, as you know, and I think is this Alex, Ellie's brother. So what we're here to do this morning is to examine Ellie's chest. So the first thing we want to do is just simply observe Ellie sitting on her mum's knee. And I'm going to start off doing that sitting down because small children don't like tall adults looming over them. So if you're sitting down, it puts you on more or less the same level as the child, and it's obviously less threatening. I'm also going to start at a little distance from her, so it gives her an opportunity to get to know me before I have to move in further and do the more detailed part of the examination. So just looking at her there, I can see that she looks lovely and comfortable. She's happy and smiling and very alert. And she's not using anything to help her breathe in, for example, oxygen, and she doesn't seem to have brought any inhalers with her. I'm now going to move in a little bit closer so that I can look at her hands. Oh, what was that? That was fun, wasn't it? Do you want some? I'll put some on you. Let's look at your hands. Are these your little pandas? Let's count those little pinkies, eh? Oh, yes. And I can see her hands feel nice and warm and that they're a lovely colour. And if I do a capillary refill time in this way, then I can see that it was less than 2 seconds. So that tells me that she's well perfused, which is really important. Next, we want to assess for hydration. So I'm feeling her fontanelle. I'm looking at her eyes, which are bright and shiny. Inside her mouth, it looks nice and damp and wet, so that all looks good. And if we do a little skin turgor, we can see that bounces back nicely. So she's very well hydrated. Okay, so that concludes our first initial observations, and I now want to have a look at her chest. So would it be all right to just slip her top things off, please, Sophie? And I should also point out at this point that her breathing sounds nice and normal. It sounds nice, quiet breathing, not noisy. Noisy breathing means that there's something wrong. Breathing should be quiet. Also, I can tell she doesn't have a cough, which is another important point to notice. Okay.
Can you hold this for me, Alice?
So, we'll now commence our second set of observations. And what I'm looking at is just looking at a chest straight on. And I'm first of all looking for expansion, and I can see that the chest is expanding nicely on both sides and it's roughly equal. In an adult, we often actually put our hands on the chest to check the expansion in this sort of way, but because she's only little, she's too small to do that, so it's best just to do it by observing. I can also see there are no signs of respiratory distress, and what I'm actually looking for is to see if there's any intercostal or subcostal recession, if there's any tracheal tug or abdominal breathing, and there's none of those things. The next thing, I want to count her respiratory rate, and I've got my watch set here, and we normally count it for about 30 seconds. So I'm starting watching now. And just while we're watching, just to remind everyone that when a child is born, they have quite a fast respiratory rate, more than twice as fast as an adult's. And then through the child's life, the rate gradually goes down until till adolescence, when it becomes the same as an adult. So that's about 30 seconds, and counting the respiratory rate, it came out at about 25, which is about right for a child of her age. Okay, so we're going to move on to auscultation now. And when auscultating a child's chest, it's important to remember that the heart has a larger surface area than in an adult. So you need to listen a little bit round the edge of the chest so that you're getting the lungs. Can I have a little listen? Just start there. Oh. Good girl. The axilla. And a little tap. You are a good girl, aren't you? Okay. Can we listen at the back, please, if we just turn around a bit? What's that? What am I doing? Okay. Well done. Clever girl. And percussion the same, in the same places. So you notice that we start auscultating near the top, and we make sure that we listen in opposite areas all the way down, comparing each side and making sure we avoid listening over the spine. So her chest sounded lovely and clear, so that concludes our examination. She's got a nice normal chest. Thank you very much. Remember when examining the chest to start with general observations, so you're noting the general well-being and colour of the child. You need to note any accessory equipment and note the perfusion and hydration status. Then move on to specific observations of the chest, noting any signs of respiratory distress, count the respiratory rate and note the chest expansion, and listen for extra clues such as cough or noisy breathing. These are suitable positions to auscultate and percuss the chest. Remember when listening that the heart has a larger surface area in a child than in an adult. At the back of the chest, remember to avoid listening over the spine. The respiratory rate of a child is faster than an adult. It is fastest at birth and gradually decreases over the child's life until reaching adult values at adolescence.
Okay, now, if you notice, this is a teaching video, so you notice if the younger the child is, the more flexible you have to be when you examine the child, okay? So cannot be too rigid, the book say must sit up straight or must be 45 degrees on the bed. The younger the child is, if the child is adequately exposed, sitting up relatively in a good position, that's acceptable enough, okay? Because you don't want to risk like moving the child, a 1-year-old child onto a bed where the kids are sleeping. So the kid, like just now the kid's happy sitting on the mother's lap, sitting up straight, that's an acceptable position for a young child. If the child is 5 years old, 4 years old, obviously get a proper positioning. Okay. So the other thing would be exposure. So the younger it is, the easier it is. I just take off the shirt, isn't it? But if you reach around the age of 8 or 9, if you're a girl, then you have to be a bit more careful. Okay. Now, she said something about counting the respiratory rate over 30 seconds. For medical students, you guys learn to count respiratory rate over 60 seconds. 1 minit bukan 30 saat. Okay? So 1 minute. And then, what's the other thing that she did? She auscultated first, then she palpated. For all intents and purposes, as medical students, you guys need to learn to follow the structure. So usually it's observation, palpation, percussion, then only auscultation. Okay, so you try to follow that as much as you can, unless the kid really, the moment you look at, start screaming, right? But if the kid was quite okay, happy kid, no, not scared of you, then don't straight away, I'm going to auscultate first. You still need to do observation. You observe the child, count the respiratory rate, do the general examination, cyanosis lah, carabing lah, tail or not lah, just that thing. Count the respiratory rate. I mean, proper exposure, count respiratory rate, look for recessions. Then you need to palpate. So palpation would be trachea and then the apex beat, right? Because you got things like dextrocardia, so the heart being on the right side. Then you got things like lung collapse. So your trachea might shift to the side where there's a collapse, right? Or you got things like pleural effusion, where the midline is shifted to the other side. So you still need to do palpation, trachea position, and apex beat. And then you do chest expansion if the child is big enough and old enough to understand you. So if just like just now, the example cannot do because that kid is roughly about 9 months old, 9 months old to about 1 year old. Chest wall, too small. Thoracic cavity, too small. So even if you do chest expansion, all you're going to see is, cannot see whether it's adequate or not, isn't it? And then the other thing is you want to see whether it's equal, unequal, or whether it's equal, isn't it? But if your chest cavity is only this small, can see or not? Cannot see also, right? So you can do chest expansion if the child is big enough for you to get your hands around it and actually make a difference. And if the child can understand you when you tell him to breathe in deeply and breathe out. Because if you do for adults also, you have to ask the adult patient to breathe in and breathe out, right? That's the best effort. So if the kid is like 6 years old, but autistic, don't understand what, on the severe end of the spectrum, don't understand what you're trying to do. When you do this, you ask him to breathe in, he just, so also doesn't do much, doesn't give you any information, right? So that's that is chest expansion. After percussion, then only auscultation. Okay, unless when you go near the child and the child starts screaming his head off, then fine, you wait until the child's quiet, then maybe you auscultate first. But even if you auscultate first, you still need to go back to percussion after you have auscultated. Understand that? Okay? The other thing you need to complete is, usually you tell them you want to complete the examination by feeling for the notes and also to feel for the liver, whether the liver is pushed down. In things like acute bronchiolitis, you get hyperinflation of the lungs, right? So the liver will get pushed down. Okay, so you will see that the younger the kid is, the more flexible you have to be. The older the kid is, the more you need to follow your steps.
Hi, Dad. Hey, Adam. We're going to be checking Adam's respiratory system today. Would it be possible to remove his shirt?
Yeah, no problem.
That'd be okay.
Slightly tangled.
You're totally tangled there. There, so we've got some home oxygen here. Oh, and we've got a book, Miffy's Birthday. Oh, very interesting. Okay, so just having a quick look around. Okay, is this a baby grow?
It's a vest.
Yeah. Okay.
But so I can push it down.
At least, okay, so you
might be easier to push it down rather than.
Oh, I see what you're saying. Yeah. Okay, sweetheart. You are very active. Am I allowed to know how old Adam is? Dad, how old is Adam?
He's about 20 months.
I'm going to be cheeky and ask what his corrected age is.
Which is coming up to 18 months.
18 months, okay. You can see lots of cannulation scars there. Can you see? Hey, are you waving? Are you waving at the pretty lady? Hey, there we go. Okay. I want to try and have a look at his fingers. They look lovely, beautiful and pink. Okay. Oh, you're going to read me a story, Adam? Yeah. You're going to read me a story? No. So it's obvious that he's got some home oxygen connected with cannula. Can we see how much is he on now? Dad?
He's on 0.2 of a litre.
0.2. And is that normal for him?
It is, yeah.
During the day. Okay. Oh, what's in there, Adam? And I'm trying to have a look at your face. Adam? 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 Who's there? Have a look. So he's beautiful and pink and he's not in any respiratory distress. There we go. Have a look at that book, and I'm now having a look for some scars. There we go. And he's got an obvious gastrostomy there. And that was laparoscopically done. Yeah.
That's keyhole.
Keyhole,
Yeah.
yes. Hey, sweetheart. I think I just want to come around the back and see if there's a scar. And he's got a left lateral thoracotomy scar there as well. Perfect, big guy. Hey. Should we turn the book so that you can read it? How about that? What about that way? Hey, there we go. Okay, I'm just going to be opportunistic and have a listen. Oh, he's happy now. We're going to have a quick listen. What's this? Is there any... Oh, we listen to the bunnies first, then we listen to Adam. Should we listen to Adam? Should we listen to Adam?
Do you want me to order that?
There we go. Very interested. Or should we listen to Daddy first? Should we get Dad to come here?
No, I
To
can
Dad.
do that.
And then we listen to Adam. There we go. There we go. What's this? What's this? Hey, big guy. You are very active, and you've got a nice BCG scar there as well. Okay, you don't like this, do you? Perfect. Okay, I'm not able to hear too much because he's not enjoying that. Can we have a listen to your back now? Should we try the back? Should we try and switch you around? So, Dad, let's switch positions and I'll come sit up there next. You look at Daddy.
You see the chat? The flowers.
I'm going to try and percuss and see if he'll tolerate that. Tap, tap, Adam. Perfect.
Not bad. Meaning.
Is that Mr. and Mrs. Bunny? Yeah.
That's the bear. That's the bear.
Here we go, Adam. You've been a star. To complete my examination, I'd like to have a feel of his tummy. How do you think you feel about lying down?
Yeah, you
Would we be okay? Should we lie you down, big guy?
Ask him.
Here we go. We're going to go sleep. There we go. Any pain in the belly? You tickles. You tickles. Hey, sweetheart. Okay, big guy. There we go. Fabulous. Just check for swelling. Those fancy shoes, hey?
Take them off if you want.
Oh, it's okay. Would he just have some other cannulation scars on his feet?
Yes, yeah.
Okay, so you see, the younger the kid is, the more flexible you have to be. Then the other thing you notice is that the person examining is the one that's moving around rather than moving the patient and manipulating the patient too much, because the kid's happy as he is, isn't it? Like, I mean, it's easier for you to move rather than for you to move the patient and irritating the patient, basically. Right? So this will be a slightly older child. When it's an older child, then you can see that they basically follow the adult way of doing things, because there's no reason for you to skip.
Okay, so we're going to demonstrate a respiratory examination now. Hi, my name's Emma. I'm one of the doctors. Is it okay if we have a look at your chest today?
Yes.
Okay, I'm just going to wash my hands. Okay. So first I'm going to have a look around the bed and see if you brought anything with you. Can't see anything, so we'll move on now and look at your hands first of all. Can you see your hands? Very good. Turn your hand over for me. So looking for any hand signs of respiratory disease, particularly clubbing. Could you point your fingers in the air like that for me, and then point them down to the ground, and then stick your nails together. Okay, so she doesn't have any evidence of clubbing. Good. Just going to check your pulse. So doing pulse and respiratory rate at the same time. Good. Okay, we'll move on and have a look at your face now. Can you copy me and pull your eye down like that? Put it a little bit more in the middle so I can see. Let me help you. Okay, very good. So looking for pallor. Then can you open your mouth for me and stick your tongue out? Okay, good. And no central cyanosis. I'm just going to feel in your neck there. It might feel a little bit funny, okay, but it'll only be quick. Okay, so trachea central. Can you pop your hands on your hips for me like you're really cross? Okay, good. For any scars? Okay, can you sit forward for me just for a moment? Okay, good. No scars there either, and just rest back. Okay, now we're just going to feel for your heartbeat. Okay, good. And now I'm going to put my hands on your chest like that and ask you to take a nice deep breath in for me. Is that okay? Just push your arms down a bit to the side. Good. Nice deep breath and out. And one more. Okay, good. Very nice. And now I just need to tap on your chest, okay? Funny, isn't it? Okay. And now if I could ask you just to take some nice breaths in and out through your mouth in your own time, that would be great. Perfect. Good. Very good. Okay, just sit forward for me. We'll do the same things at the back. So first the tapping and then listening. Okay, and then if you could do some more of those breaths for me, that'd be great. Okay, very good. Just while you're sitting forward, I just need to check the glands in your neck. So do you mind staying forward for me for a moment? Tell me if it's sore at all, okay? Because sometimes it can be tender under there and I won't be able to see your face, okay? It shouldn't be sore, but it can be sometimes. Good. Is it ticklish? Okay. Good girl. Just okay, good, brilliant. Just rest back. So we'd conclude the examination by checking for hepatomegaly or displacement of the liver and checking her peak flow and oxygen saturations. Great, thank you very much.
Okay, so like I said, the older the child is, the more you follow the adult way of doing things, okay? Any questions now? I'll show you some more video and then we're done. I think it's one more video. No, it's not one more video. Extra stuff. What's the extra stuff? Okay, tell me what you hear, okay? I think the answer is that. Okay, Rongkai wheeze is expiratory, right? Stridor pernah dengar tak? Have you heard of stridor before? Yes or no? Have you guys heard of stridor before?
Tengok video je. Video doktor.
Video lah, dia buat tengok video lah. Video lah tak pernah. So stridor is usually inspiratory. Wheeze is usually expiratory. Okay? So, because a lot of people tak pernah dengar, I think this is stridor.
Nah, he don't.
So that's very short. So that's stridor. So it's inspiratory, right? You can hear it. And then you can see the child has intercostal recession and subcostal recession, right? So that's inspiratory, stridor. So things like croup, in very young babies, you think of things like laryngomalacia. Even at 2 weeks old, the mother notices some noisy breathing, and then progressively seems quite loud, especially if the kids active. So that might be laryngomalacia. It's an acute illness together with fever, then you think of croup. Alright, so we should be this one.
You will probably have it. The wheeze sound is often described as a musical sound, made as the child breathes out.
So this boy is a wheeze. You can hear him. If you look at him also, you can see that there's prolonged expiratory phase.
Notice that wheeze is always heard as the child breathes out, but that the actual character of the wheeze sound can vary from child to child. Let's look and listen again. In addition to the wheeze sound, you may observe the following features. Look closely at the child's chest. The child may be taking longer to breathe out than breathe in. A child with wheeze may also have chest indrawing. The child may have to make an effort to breathe out. This may result in respiratory distress, with the child in obvious discomfort and experiencing difficulty in talking, drinking, or breastfeeding. In order to observe these additional signs, you must look carefully. You should not expect to see or hear all these signs in every child with wheeze.
This one cannot really hear anything. So that's a wheeze. And the first one was a spider. Okay, so when you look at a wheeze and its ronchi, usually you observe the tip so you can see when they breathe in, when they expire, the expiratory phase actually prolonged. So as medical students, ronchis are all expiratory, spiders are all inspiratory, okay? As medical students, if Dr. Fadil asks, his level is different, okay? So expiratory ronchi, inspiratory spider, okay? Now you're gonna watch this guy is a pediatrician in the US, but basically he has a YouTube channel. Don't watch it blindly because there are some things that I don't agree with. Okay, but I just took this video because it goes with what we're watching today, what we're learning about today. Okay, so there are signs of respiratory distress. Try to note the signs of respiratory distress in the kid. Take note of the history of it. Okay, listen to how the kid coughs. Because if you go to the pediatric ward, that's the kind of cough that you hear. If it so happens that you go to his YouTube channel and you start watching, don't take everything at face value. You understand what I mean, no? Because I don't agree with everything that's on his channel. Okay? You say, oh, Dr. Chan showed us this, so it should be okay. Every single video is different, so if you watch, you decide whether if it sounds off, don't take that video as fact. You get what I mean, no? Okay?
Since Monday, the coughing has been worse, and she coughs sometimes so hard she throws up. More than spitting up, but everything.
Okay.
But not every time she eats. And she's just coughing hard. And today she was having rapid breathing of more than 60 per minute. So we thought, okay, we need to bring her in and get her checked out.
Yeah. Dr. Paul here. We've got a 2-month-old that's having trouble breathing. Let's go take a look. Hello. Hi. You're back.
We missed you.
Oh, golly. I hear you're having trouble breathing. This little one is 2 months old. Started out a few days ago with a little bit of congestion, and then it's just gotten worse and worse.
So 2 months old, difficulty breathing, congestion meaning tough nose, right? Those are the terms that they sometimes use in the US. So congestion meaning blocked nose. So 2 month old respiratory rate normal should be less than 60. So technically will be more than 60.
And when I saw them a couple days ago, I'm thinking, well, it was a little croupy at that time, a little hoarse voice, but the age is just right for bronchiolitis, which is what we're seeing. 2 most important signs to watch for is a little baby getting in trouble is if they're breathing faster than 60 breaths per minute. That usually correlates with the oxygen levels dropping. And if they just can't stay latched, or if you're bottle feeding, they can't keep the bottle in the mouth, they're just suck, and then gasp for air. So I like to observe.
So things you need to watch out for is when you ask the mother is one, how is the child feeding? And child feeding is normal or not? Can you hear me or not, by the way? Is the child feeding well or not? Right? Is the child taking less than usual? When the child, let's say if the child is bottle feeding, does the child take longer to finish the bottle? If the child is breastfeeding, does the child need to take more breaks at shorter periods of time? Right, so that's an indication of how bad whatever respiratory tract infection is. And then mother should usually notice how fast the child is breathing. The thing about patients in the overseas, they tend to be given patient education, so they kind of know that they're supposed to count respiratory rate at home, right? So they kind of know that over 1 minute they're supposed to count, and if it's over this number, the child is breathing fast, right? It's different from our situation here, right? Most of the time the parents can just tell you, oh, you know, either they don't know or looks fast. That's all they can say, isn't it? But overseas, sometimes a lot of the parents are taught to count the respiratory rate by the pediatrician. Because a lot of times they don't come to the casualty, they kind of go to the doctor, and then the doctor will see, oh, okay, the kid looks well, or looks okay, but then you need to monitor the child. This is what you look for. Then you send the child home with medication. Right? Come back if the child is like. Here we don't tend to, right? Here they tend to go to the klinik kesihatan. If they see the MA nampak semput bagi nap, dah lepas nap nampak okay, then balik rumah. Betul tak? Then don't really tell the parents when to come back, if to come back. Right? Sometimes you see the doctor may, depending on who you see lah, the doctor may remember to tell, look, if your child looks tachypneic, cannot fit well, then you need to come back. But a lot of times, the advice is kind of missing.
1, 1002, 1003, 1004, 1005. So that's about a 50 something, you know, maybe even a.
That's how you agak-agak respiratory rate, isn't it? If you want to agak-agak, because 1,000 supposedly 1 second. 1,000, 2, 1,000, 3, 1,000, 4, 1,000, that's supposedly 1 second, 1 second, 1 second. So if they're breathing like faster than 1,000, 2, 1,000, 3,000 respiratory rate, definitely more than 60.
Getting close to 1 breath per second, which is 60 breaths per minute. We do have a pulse oximeter. We checked it. It was 98 on room air last time, 2 days ago, 98 again today. So it's not quite bad enough that you have to be in the hospital. But you didn't know that at home.
No.
You've got a kid that's breathing 60 breaths per minute, and you know, you go, wow, I wonder if they need oxygen. And that cough, that's a bronchiolitis cough.
So basically, it sounds like there's a lot of kaha, isn't it? So kind of like that thing.
And that's probably RSV. We didn't check last time, did we? So I think we should do that. We should just go ahead and make sure we know exactly what we're dealing with. So we're going to do a little nose swab, if that's okay with folks. Yep.
We'll hold her head up so it stays. That way I'll have better.
Switch hands.
Okay, sure. Okay, all right. You hold her head nice and still for me. Oh. Okay, we're just gonna go up there. Oh, with that booger. There we go. Slurp. Plop, 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 plop. There we go, folks.
There's an RSV kit. We don't use it with him. Okay.
The thing about RSV is it is a virus. For the older kids, it's just a cold, which is what they experienced. But for little babies, they can get a pneumonia and really struggle to breathe. You know, you just get secretions building up in your lungs, and occasionally you get hospitalized. We're still hopeful that won't happen. I don't think it needs to happen just yet, but babies will get sicker for the first 2 to 3 days, even up to a week. And we're now several days in, right? So hopefully this is the worst. And then you have good days and bad days as you get better over, they say 2 weeks, but I've seen this last a month.
Sure.
Yeah. Here. Wish I could get the viewers to listen. The right upper lobe is crackly. Right upper lobe, the patient's right, left, right lower, left. And it's just very crackly up there, but good news is the rest of the lungs are clear.
What does crackly mean?
Well, when you get fluid in the alveoli, which are the little air sacs, they'll just, when they try to pop open, as they pop, they make a little crackle sound. We rub our hair together to illustrate to students that that's what it sounds like, is that popping sound. So this is a little pneumonia that almost certainly, that's common. And then you hear pneumonia, it sounds, oh no, that's terrible, right? You don't have to panic. It's pretty typical with the RSV that it can go into the lungs and then it's got to work its way out. One of the things you can do is cup your hand and just kind of whack. I'm hitting hard enough to sort of jolt, but not too hard. If you slap, then it hurts, but you just cup. In big people, the RTs will come in and do physiotherapy, right? You kind of can do a little bit of that with a baby.
Explain why.
Well, it just might help loosen up some of those secretions. Babies have a really hard time mobilizing secretions. If they cough, they never cough anything out.
Right.
So secretions are going to just need to be absorbed. And the key is that we not get so sick with fluid in our lungs that we can't get enough oxygen. And a baby who's struggling for oxygen won't stay latched. They're pulling off and gasping for air. They start breathing more than 60 breaths per minute. And there's still a slight chance. I'm not trying to scare you, but you're going to keep watching, obviously. This is a progression, and I'm hoping we're at the worst. But if it gets much worse, you would end up in the hospital. All they do is oxygen.
Okay.
I mean, seriously, it's not a like, oh, scary thing.
It's not. We're putting you in surgery and you're going to be in the hospital
Right,
for 6
right.
months.
It's like if you're not getting enough oxygen, they'll start with a little nasal cannula and just blow a little oxygen in to keep their oxygen up. And they cough and you nurse, and it's just the same, but a little support. I like to see this. If we look at the... very little tugging and pulling, to move air. And that's because most of the lungs are clear. So when you have, so let's say the pneumonia got worse, it's going to require so much force to get air in because they're just full of fluids that you'll see between the ribs. You'll see the ribs.
Deeper.
They just appear each breath. And you can see it.
So a little bit, that's not freak out.
Yeah, that's tiny. And we had noisy breathing, but when it goes quiet like that, and I go, oh, that's really good. Because the babies who are in trouble, they're grunting and never quiet.
Oh.
They're just like...
So her sometimes during the day being very noisy and sometimes being like this, that's better than that's
fine. Yeah. So the main thing we're going to watch for, if breathing becomes difficult in a little baby, what does that mean? Well, you're breathing faster than 60 breaths per minute. And I always add on here, can't nurse, or if you're taking a bottle, you really can't take the bottle. Those are your big clues that you've got to get seen again. And if you're at home with a kid who's, acting this way, congested cough, they're real little, they're starting to breathe fast, if they're way below 60, they're nursing fine, you're not in trouble. It's okay to just keep feeding your baby. So if you're working or living in a place where you don't have access to a rapid RSV test, it doesn't change a thing. Pediatricians, when they see this, we've seen this 1,000 times. If you've been doing this for a while, 100 times if you're newer. This is RSV bronchiolitis, and an infectious disease doctor once told me, I was asking him, well, how do you know? You haven't proven it. He says, if your mother was standing in front of you, would you know that was your mother? So, okay, all right. When you've seen something enough, you just know. Feed, 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 because when your baby, let's say they're borderline, they're getting close to being in trouble, they're not as...
This part I don't agree. You say feed. But your child static neck, don't force it, isn't it? Right? There's a risk of aspiration. He's saying that you need to feed the child so the child remains hydrated. So the child doesn't become dehydrated and have that energy from the milk. That part just ignore. If the child already static neck, then. But if the child looks okay, just like coughing, not really technique, little bit of recession, then you feed smaller amounts a bit more often, right? But the child already technique, showing signs of respiratory distress, then you don't have cough. Okay, so that is all the videos for today. Anything? Tak tanya? Mungkin dah tak ada dah. Ada dia? So you see? Okay. Anything you want to ask before we look at x-rays? Tak tanya lah? Tak ada. Tak ada giling kepala. I can see all your faces, especially Balkis. Balkis tutup. Kyrie, Lina pun tutup. Afiza pun tutup. Okay, we look at x-rays. Siapa nak jawab? Siapa nak discuss? Buka. Just unmute yourself and answer. Okay, who wants to describe what they see? If nobody want to say anything, I'm going to call names. Siapa tak kena lagi? Saat dah tanya mana soalan. Husna dah kena kan? Okay, Farihada. Lina, what do you see? Cannot hear lah. Kuat sikit. Let's describe one thing that you see. Now, that being said, it's very hard to differentiate acute bronchiolitis from bronchopneumonia. Okay, there's bits and pieces here and there. You will say that acute bronchiolitis is a bit more fluffy. Very high, if you need slightly a bit more fluffy. What do you see? The legend cakap apa?
Patient opacity tak?
Kat mana? Sini?
Dekat, bukan, san. Left, dekat left upper lobe dengan right upper lobe.
Sini? Here is it? Can see my cursor or not? Nampak cursor? Sini? Okay, actually, okay, first things first. Rib cage. Lung volume. What do you think about the lung volume?
I think it's normal.
You think it's normal? Do you think that the ribs look like especially horizontal? Like
Yes.
1, 2, 3, 4, 5, 6. The anterior rib only starts to cut the diaphragm at the 6 rib. It's hyperinflation, isn't it? Right? Very young babies, you say 8 to 10 is normal. 8 but posterior ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Just at the borders. And then your ribs are flattened. So this is hyperinflation. Tarihala, trickiness, right? This would go more for acute bronchiolitis and than pneumonia. But that being said, it's very difficult to differentiate pneumonia from acute bronchiolitis based on chest X-ray. This will be air on M, right? Bubogram scan. When the bronchus look at you straight, so that's why you see more loosened there. Okay. Next. Hafiza, describe.
Yes. The heart shape.
Sorry?
The
heart shape. Okay. What's this? If I tell you it's a very young baby, what do you think this is? The heart is here, right? Okay, you think it's a mediastinal mass. In a very, very young baby, if I tell you that this is normal, what is this? What structure is this?
Thymus.
What structure involves? Yeah, it's a thymus. So in a very young baby, sometimes you look at X-ray, you can see this, or sometimes you can see like a triangle there. Sorry. Sometimes you can see a triangle there. That's actually the thymus. So thymus involves by the time you are 2 years old, isn't it? So if the child is like 6 months old and you nampak macam ni, examine lah, make sure that your apex beat is not displaced, right? You want to say the child has cardiomegaly, make sure that apex beat is not displaced. Make sure your heart sounds are normal. Most likely this is the thymus. This one just shows hyperinflated lungs. Then this one the X-ray is a bit overexposed, so you can see all the where the air is supposed to be, isn't it? A bit of trickiness here. Supposedly bronchiolitis lah. Okay, this one. What's this? Anybody? Okay, first thing, it rotated, kan? The film rotated, right? Not straight on. But this one looks like what?
There's a consolidation at the right upper lobe.
Okay, consolidation at right upper lobe. That is possible. Can also be a what? If it's a consolidation, you think it's what do you think it is?
Pneumonia.
Pneumonia.
A pneumonia. Sometimes you can also get a lung collapse.
Collapse.
Collapse of the right upper lobe. So acute bronchiolitis, sometimes when the diffusion blocks, you can get a little bit of a collapse of that. Also, if you see this kid exposure to TB, then you think about TB.
TB.
Not miliary lah, miliary. Miliary will be all over, isn't it? But this one will be a right upper lobe collapse, easy macam tu. Now this is obviously a pneumonia because the opacity is homogeneous kan? Betul tak? Right? It's basically a consolidation. You can see air on end bronchograms there. So that will be a pneumonia. Loba. Right? What lobe is this? Lobar pneumonia or bronchopneumonia? Pareha, lobar pneumonia atau bronchopneumonia? Lobar ke broncho? 10%. Yes, 50% of getting it right? Lobar pneumonia or bronchopneumonia? You see? Nicely demarcated. Pareha! Guess!
I
It's
think
50%. Lobar or broncho?
it's look like loba.
Lobar, right? It's right over here. And this is the lateral, you see, it's nicely demarcated. So which lobe? Afiq? Tahu tak which lobe? You know it's the right, so which lobe?
Middle lobe.
Yay! Right middle lobe. No need to send you back to your anatomy teacher. This will be what? Like I said, acute bronchiolitis and pneumonia cannot really see the difference that much. But anyway, you can see bilaterally fluffy opacities, right? All the way here. So it'll be a bronchopneumonia lah, basically. Once again, if you see without context, without your examination or without your history, it's a bit difficult to say, oh, that's pneumonia, right? But you can see, right, it's a bit more hazy, right? Here. Here. I think that is it. Last one.
Doctor, previous slide, about the trachea, is it normal?
It's slightly rotated. Yeah, it's normal. It's it looks like it's pulled towards the right sikit kan. You have to see whether your film is rotated. The film is rotated, not so you go down your spine straight, no. Then you see your interclavicular space equal, no. Yeah, slightly pulled to this side. So there's a pneumonia there, isn't it? It's normal in the sense that this part is because the patient probably pushing the kepala a bit, but it looks like the trachea is slightly deviated to the right. Maybe there's a correct consolidation here lah, pulling it aside. Because your heart also is supposed to be more here, kan?
Doctor.
Yep.
Doctor, is it ground glass appearance in this chest X-ray?
No. If you're talking about ground glass appearance in RDS, it's not like this. It's like you see the opacities, right? Mainly concentrated over here, okay? And mainly over here, right? Now, if it's ground glass, it's all over.
Okay.
Wait, I get a ground glass appearance here. Oh, no wonder. Ground glass appearance, I think you Google ground glass appearance, you see it's all over, the opacity to be homogeneous one. I cannot seem to get it to... Not pneumothorax. You see the pneumothorax there, right? Okay, this will be ground glass appearance. You see, it's homogeneous, and then it's like kind of wiped out, but you like got grains on it. This is ground glass appearance. Okay?
Okay, there.
Okay, so we are done for the day. Tapi jam setengah. Cukup? Okay? Anything you want to ask? Not before bye-bye.
Yeah, dah.
Okay, bye-bye.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
You need the link tak payah kan? You can search yourself, right? If you can search all your videos, so you can see yourself, kan? Okay, bye-bye.
Alright, bye-bye.
Bye. Thank you, Doctor.
Thank you, Doctor. Buat apa ni? Aku live lah. Boleh tak?
Ambil gambar tu.
Okay.
Tak boleh.
Ambil gambar. Nina.
Buka balik video ke? Kena charge telefon lah.
Sekejap nak ambil gambar. Azilia.
Ada kah?
Oh, Isya.
Aku nanti nak kena repair. Yang tengok ah. Dah
Beli
dia
baru
kata
je.
ONG. Dia kata ONG kena buka kamera kalau tak Dr. Kit tu aku.
Oh, dahsyat kan?
Ha.
Matilah.
Korang kira tengah record ni kan? Aku nak live.
Hari tu parah.
Oh ya, tengah record. Sabar.
Ambil gambar Pak.
Cepat lah.
Ui, penat
Senyum lah. Dah.
Dah.
Bye.
Bye-bye.
Hafiz ni Hafiz.
Dah.
Okay. Boleh lah.
Dah.
Okay, korang.